Greetings to all of you. Hello, everybody. My name is Konstantinos Donas. I am professor of vascular surgery and head of the Department of Vascular Surgery at the Asklepios Klinik Langen in Germany. I have the privilege today to organize and express my deep thanks to Radcliffe, a nice webinar focusing on venous pathologies and disorders. This is a joint activity, joint meeting with Venous Symposium Europe. And I'm more than glad to have a distinguished speakers and panels together with me. Professor Makis Avgerinos from Athens Medical Center, Professor Houman Jalaie from University Center of Aachen, and Aleksandra Jaworucka from Poland will have together with me the privilege and with you as audience to interact together and focus on vein pathologies, on vein disorders, starting with interesting cases on acute DVT lesions. How can we treat these issues? We want to hear from Dr. Jalaie about chronic venous disease and obstruction, and of course, very interesting topic, the pelvic venous disorders from Aleksandra Jaworucka. So let's start. More than glad to welcome and give the hello and the micro to my good friend and distinguished colleague, Makis Avgerinos from Athens, Greece. Dear Makis.
Well, Konstantinos, it's a great pleasure to join our efforts for your Advanced Vascular Conference. We are all looking forward to be there. And we are glad that this year you are including like a more advanced and comprehensive venous program. Hopefully this will be the first of many to come. And it's a great pleasure to collaborate as Venous Symposium Europe, which just started a few months ago, launched in Greece, and we will also hopefully have it for many years to come. Now, jumping straight away to my topic on acute DVT intervention, I will share a couple cases, but I would like to say I'm not here just to make a presentation. I would like it to be interactive. So I would ask all of the panelists, Houman, Aleksandra, please jump in, or you, Kostas, please jump in to ask questions on how you would treat it and what would you do if this was your case. And of course, our audience, please feel free to enter your questions. We have a live Q&A, so please ask as the presentation goes on. These are my disclosures, and here is my patient. This has not been done long ago, it's a few months ago. So it's a male patient, 74 years old, gastric cancer, chemotherapy. He underwent total gastrectomy, and post-operatively, I think it was a couple of days later, developed post-operative upper airway obstruction, and he had to be reintubated. So the duplex ultrasound confirmed left IJ thrombosis. The right IJ was patent, but he also had right subclavian vein thrombosis. He has a port, by the way, and through that port, he was getting his chemotherapy. The port is on the right side coming down to the right subclavian, I think. Let's move on to the next slide. So I will show it slowly. Focus on the right superior vena cava. Look at the port. There is thrombus in the superior vena cava. There is thrombus in the right atrium as you come down. Look at it again. Right IJ, right subclavian vein. Look at the superior vena cava. The port is in there. There is thrombus, and the thrombus extends down to the right atrium. Let's look at it more carefully. The right jugular vein, it's open. The right subclavian vein seems to be thrombosed. The left IJ is thrombosed. If you move further down, you see thrombus at the right illuminate vein. Look now at the superior vena cava. Look at the port inside it. And there is thrombus around the port. And if you look further down, there is also, look at the thrombus going into the right atrium. So what would you do in your case? Any of you, please jump in. I mean, we have the patient had to be reintubated. There is a lot of swelling. This is superior vena cava syndrome. There is a port in place. Would you just do anticoagulation? Would you consider removing the port? How would you manage it in your practice? Kostas, Houman, Alex, there is no single right answer.
Yeah. What kind of symptoms really did you observe?
So he had to be reintubated because of his airway is getting obstructed.
So probably you need a more, let's say, radical solution than anticoagulation.
Marquis.
Yes, Houman.
That is an acute SVC syndrome in this patient with left jugular, right subclavian, and brachiocephalic, and a part of SVC. So the patient, there is no question that the patient needs a therapy, a treatment. And the treatment shouldn't be a conservative treatment, it should be an invasive treatment.
So, right, I think we waited for a couple of days with anticoagulation, but we didn't see any kind of improvement. So we decided to intervene, otherwise he could not be extubated. So there are multiple ways you can intervene. I'm in favor of mechanical thrombectomy. And my plan of attack would be to go through the groin and get my aspiration catheter up into the superior vena cava and try to remove the thrombus from there. So let me show you how I accessed it. So the patient is getting worse. You see on anticoagulation, there is no improvement. You can tell his face, how things are progressing. So I have the dry seal sheath, that's a 24 French sheath, up into the inferior vena cava. You see with my catheter, I can only see the thrombotic material coming from the SVC. And I'm trying to navigate my wire up. So for whatever reason, I was lucky. That was the only way out. The wire went through the port lumen. So now I have a wire going through the port and coming out of the port. So what I did, I just removed the port and now have wire access into the subclavian vein. You can see now how I'm advancing. That's the flow trigger device. We are using it for pulmonary embolism. You are aspirating. We have a 60 cc syringe on the back. You can see the animation. Every time I do a suction, I bring back 60 cc's of blood and thrombus. So I'm emptying the SVC and the illuminate vein. Now, I need to establish flow coming out of the IJ. So the only IJ that I have open is the right internal jugular vein. Houman, are you happy to bring one IJ back, or you would like both IJs? Would you fight to get the second jugular vein back, or one is enough to decompress the face?
It is enough to decompress the face, but if you are in place now in the SVC or in brachiocephalic, in confluence of the brachiocephalic veins, and you have the catheter, maybe a try is okay, but do not fight for it, especially not in this patient.
So I agree. I tried a little bit to get my wire to the left side and potentially do kissing stents coming down. However, my wire would not go to the left side. So I ended up with a single wire on the right side, and I knew the right IJ is patent. And we know that one IJ is typically enough to decompress the face and the brain. So I have now one wire going to the subclavian vein, and I have another wire going to the IJ. I keep on aspirating, getting into the IJ. And look what I removed. So this is what I removed from the superior vena cava, the illuminate vein and part of the IJ. So this is what we have now.
Beautiful.
It's okay, but it's not okay. So what would you do? Now, I
not
do have flow, but the right atrium is still there. The problem in the right atrium is still there.
Yes.
Can you give us also feedback about your setup in the OR? I mean, which kind of background, let's say, support do you have from the anesthesiologist, thoracic, cardiac surgeons? Are you doing completely alone? How is the setup in the OR? Because I think it's also crucial for the audience to have a feedback about the overall setup.
So it's definitely, it's all done in a hybrid room. And I typically like to have 3 accesses available for this patient. So I have access at the area of the port where I removed the port out because I wanted to remove the port because the port was the thrombogenic material that had to be removed. So I had access at the right upper chest. I had access at the right IJ in case I needed to go down, and I had access at both groins. I do not have thoracic surgeons in the room. It's very rare to get an injury that will require to open up the chest. Typically, venous injuries, if you more or less know what you're doing, are forgiving because it's a low flow system. Let's say you have extravasation, all you have to do is just inflate the balloon and do a weight. Or a worst case scenario, you deploy a covered stent. But I don't know, Houman or Alex, in your cases, do you have backup like thoracic or surgeons or cardiac surgeons around for these cases?
No, for these cases, not. I think Alex, neither. Alex. But as you were discussing about the extravasation or maybe rupture, yes, indeed, it is really seldom. But I had 2 cases of pericardial tamponade while I was recanalizing in a chronic obstruction case, bilateral SVC, and everything was occluded. So that is a little bit different. If you have an iliocaval area and extravasation, it doesn't make any problems. But sometimes in a thorax or central veins, you create easily a pericardial tamponade. You have to be aware of that. Both cases needed, one needed a observation, the second needed a puncturing by cardiologist.
Okay, so here I am now. I think the area down there close to the right atrium, what happened, the port in there has created like a chronic fibrosis at the superior vena cava. So whatever I could not aspirate out, I considered it to be chronic fibrosis. So here I am now, and there is the lesion that bothers me. I think if I don't resolve this, this will rethrombose.
One question from the audience before you go and present your next, let's say, step, dear Makis. One colleague is asking, what about to use another thrombectomy system? I see the name, it's mainly for arterial lesions. Angiojet is from Boston Scientific. What about penumbra aspiration thrombectomy system? Do you have any also recommendation on this?
Yes, I have used both these devices. I'm quite familiar. The penumbra, the new one, the CAT16, is quite powerful, and I think it could also work nice. The CAT16, the angiojet, I have two concerns. It's very close to the heart, and when you're using angiojet very close to the heart, you get arrhythmias. You can even get cardiac arrest. Let alone it's a relatively small device. It's an 8-French system. I'm not sure it can be as effective in removing so much thrombus from the SVC. It works great for the iliofemoral segments, but for the vena cava, it may not be as efficient. That's why I didn't use angiojet.
And another limitation is that you can use it only 300 seconds. Maybe it is enough in a central vein thrombosis. Over it, you create hemolysis because it destroys the erythrocytes outside the catheter.
Okay,
Exactly.
excellent.
Let me have my slide back, please. Okay, so what I did, considering now that I have a chronic component behind, I started inflating balloons. So you see particularly the area, I don't remember, this is a 12 or 14 millimeter or even 16 millimeter balloon. I have marked the area where the stenosis is at the junction of the superior vena cava with the right atrium. Of course, I'm kind of nervous because I'm inflating a big balloon in the right atrium. This may cause arrhythmias. Hopefully, nothing happened. Thankfully, nothing happened. So you see that the lesion is not responsive to the balloon. So what do you do now?
So it looks that it's more, as you said, fibrotic, so not elastic. So it's something, so you need more radial force to ensure the flow. So probably a stent option would be here a good indication.
Exactly. And this is what I did. And I would like now to finish my case. So the stent needs to go from a good inflow to a good outflow. So I have to extend my stent from the IJ, where it is patent, down to the right atrium. So I go with an Optimate sinus venous 14/60, and then I extend down to the right atrium. You see how I deploy it? This is a 16/120, and this covers the lesion. I do post dilatation with a 14 and 16 millimeter balloon. And look at the final result. We have spontaneous flow now to the heart. The area of the filling defect is the thrombus or the fibrotic material that I have nailed. It's behind the stent. It's not affecting the flow. And look how the patient looks. I remind you how we started. This is the patient 4 days later. Day 5, the patient was extubated.
Wow, fantastic.
So I think it's a very
really
good
those patients are really thankful. So this guy is, of course,
Look
now
at that.
intubated.
Look at the images. This is 2 months later. Look at the stent, how nice it is, widely open, going down to the right atrium.
What I like also for this stent, I don't know, you have a huge experience, Makis, on this, is also that despite that is a self-expanding, you have a very precise placement, because you know well that self-expanding stents are not so precise in the placement compared to balloon expandable stents in general. But for these specific reasons, we have a very good, let's say, considering the concept of removing the shaft, placement option.
So yes, it doesn't foreshorten like the older stents used to do. It is accurate placement, and that's a very good radial force for this kind of fibrotic chronic lesions. And I think with that, I'm going to close it here and just invite everyone, after you come to the Advanced Venous Vascular Conference in Frankfurt, please join us also in Athens in October for our Venous Symposium Europe. Thank you.
Fantastic. Fantastic case. Thank you very much, Makis. We learned a lot, and also I like it, the procedure.
So maybe one thing regarding the sinus venous stent, Makis, I think, use really a brilliant stent here. Foreshortening in self-expanding venous stents is not a big problem. But a very big advantage of this sinus venous is that it's a segmented stent and has a big porosity. So while he jailed the subclavian vein, the struts are very small. So the subclavian vein remains patent.
Thank you. This is a very good point that you bring up. We retain the patency of the subclavian vein despite jailing it because of the big porosity of the stent, the open cells. Yes.
Very nice. So I would say, let's go to the next presentation and talk. And if we have time, we can see the second challenging case from Dr. Avgerinos. We are more than glad to come to Athens and also be part of the European Venous, of the Venous Symposium Europe. Let's go with your case, dear Houman.
This
is the second case from my case.
Yes, this is acute DVT. Maybe we change.
Bring Dr. Jalai's the slides up, please.
Let us discuss another, it's coming. Another important advantage of sinus venous is because of its segmented geometry, the migration, the probability of migration is very small.
Yes. How is your experience, Alex, with stents in vein disorders in general? I have to say, personally, when I have an acute DVT lesion, I realized that sometimes only thrombectomy and thrombus removal lead to significant clinical improvement of the patient. So sometimes I don't know if it is necessary to put a stent. So in other words, arterial lesions after dissections and recoils needs per se a stent, but in the vein area it's probably totally different, the flow parameters, and sometimes only removal of the thrombus is enough for some patients.
Yeah, the truth is that I am working in a private clinic and we do not have too many patients with acute DVT, which needs interventions like Maki said. That's why, I don't have any huge experience in that area. I haven't seen such patients.
Okay.
Like Marcus had shown in my clinic. That's why maybe not my expertise in that area. But it was a wonderful, really amazing.
Houman.
Should I start?
Yes, please.
So my topic or my case is a extensive chronic venous obstruction case. Let us say patient had a DVT. I jump into the next slide. So this is the present illness and past medical history of the patient, just to show you the patient is suffering with advanced PTS, as you can see here. And very important is that the patient should be impaired in her or his daily life if they are coming with, to you with a PTS. And here, just showing to you that we are talking about a multimorbid patient, and the patient had already an open surgical approach of IVC or for IVC thrombectomy and renal vein thrombectomy, ejection fraction 30%, and 2 failed attempts of recanalization in another hospital. That is the daily evaluation of SEEP, VCSS, and Villalta, what we do, and then the nurse will put it directly into the digital system. Just have a look. We are talking about C4B on the right side and C4 on the left side. And here the VCSS is advanced, especially on the right leg 15 and the Villalta 25. And the venous patient was suffering from a venous claudication, which normally is not represented in Villalta, neither in VCSS. So please ask about venous claudication, these patients, and many of those, nearly 50%, are suffering from severe venous claudication. So now my question, I think for the panel or audience, do you see the indication for recanalization regardless the inflow and the imaging, just from past medical history and present illness? Alex? Advanced PTS, Villalta 25, right leg, venous claudication 50 meters.
Definitely he needs to.
For you, there is an indication. I think, Marquis, you agree with this?
Absolutely.
And Kostas, yeah. So patient was really suffering. So then we go to diagnostic approach. The most important diagnostic tool is duplex, and that is a duplex of the patient, of his right groin, you see post-thrombotic changes heavily involving the femoral vein and post-thrombotic changes involving the deep femoral vein, but we considered it as not heavy, less than 50%. It is not difficult. You can measure the diameter here. Let us say it is 8 millimeter or 1 centimeter, and the post-thrombotic changes are less than 50% involving the lumen. And here just showing you how involved the IVC wall was. The IVC is very small. Normally IVC is much bigger than the aorta, and you have fibrosis of the IVC wall. So then we always, before we indicate a recanalization, especially in such a case, I will show it to you, we go for a cross-sectional imaging. The patient had already a cross-sectional imaging from another university hospital because they tried recanalization 2 times. So he had an actual CT phlebogram. That was patient's venous map after duplex ultrasound. You see involvement of the iliac tract with a perfect inflow of the left side. Femoral vein and deep femoral vein were not involved. On the right side, femoral vein heavily involved, and deep femoral, we considered it as slightly involved. The entire iliac tract was occluded, and the entire...
May I ask, so in your classification, which type is it on the left and right?
I will show it to you in the next slides, but left side is a type 2, right side is a type 4A, but I will show it so it will get clear. I hope CT scan is running now. And you see that we always measure also the flow volume, here 190 milliliter per minute right side, 280 milliliter per minute left side. I know, Alex, you do a lot of duplexes a day, maybe 5 times, 6 times, 7 times more than us, but also Makis and Kostas, we can measure the flow, but it is prone to error, depending on position of the patient, the daily hydration situation of the patient, maybe the weather, so it is not very clear. But just to show you, right side was less than the left side. Any questions till now or any remarks, comments?
I like very much your sophisticated evaluation before treatment. And I think this is a crucial message for the audience. I see also several questions from Spain, from Egypt. I will answer later, because I think this is something which, as vascular surgeons, we believe we have only 3 places: carotid surgery and PAD. And I think the message is here also to learn more about the vein disorders and how you are approaching the treatment before you start, which is, I think, an important step to evaluate and understand better the disorders.
Absolutely. Thank you very much for addressing this. I think from Maki's presentation, we got clear information. Patient was symptomatic, even sleeping and intubated, but there was a problem of
Yes.
ventilation and his really severe problems, not only because we see an image, we should do it. Also from Alex's presentation later, we will see that the focus is on symptoms and not just treating something what we see. Very important to indicate, make a proper indication. Yes, now should the patient be treated invasively? We decided about it. And Alex, to your question or remark, exactly the left side of the same patient is a type 2 of our recently published classification. And the right side is a 4A. And that regards the extension of the anatomy or anatomical extension of the pathology below the ligament. And with that, of course, the inflow. The left side of the patient had a perfect inflow, very good inflow from deep femoral vein and femoral vein. Right side, the femoral vein was heavily involved. The deep femoral was considered from us as not heavily involved. So we decided, because of patients' complaints and advanced PTS, for recanalization. That is how we prep and rep the patient in those extensive disease. Right jugular raise, as Makis also showed in his case, it's always prepped and rep. The affected leg here bilaterally is prepped and rep circulatory, and so we can puncture the mid-femoral vein normally, go inside, of course, ultrasound guided. We can elevate the leg, puncture the popliteal vein. We can puncture the GSV. We can puncture the lower leg veins or the smaller saphenous vein.
Houman, regarding
Yes.
regarding the GSV, people need to understand that if you access the GSV, you cannot rely on extending your stent
Yes.
to the origin of the GSV because you are still losing a critical portion of
Important
the
part.
vein that may be
But Makis,
diseased. So how do you stent in these cases? How do
Luckily,
you
this-
evaluate the more distal part of the common femoral vein?
luckily, in this case, we couldn't get access to the femoral vein in the mid of the leg, and we got access through the GSV. So I will show it, the problem. Okay?
Okay.
Exactly. It was a very nice issue, but I will show it. Here, as Professor Avgerinos said, this is the first angiogram. The left side was easier. Why? Because the access was in the common femoral vein, because the common femoral vein was not involved. The distal part of the external iliac vein was not involved. So it was a type 2 classification. It was very easy access. The right side, we tried 15, 20 minutes. Just from logistical point of view, it was a big patient. You have to consider the femoral vein is heavily involved. Now you have to puncture in a 90%, 100% occluded vein. So sometimes I say you are disappointed after 15 minutes and you just have to leave it go on, otherwise you lose time. So we decided to go through the GSV in the patient. As you can see here, Makis, maybe it is running. No, sorry, I go back. Here, yes, now it is running. You see, it is not the common femoral vein. We come from very medial part. It is a puncturing of the GSV. So what Professor Avgerinos is telling, we will miss the pathology of the important 3-4 centimeters to the ostium of the deep femoral vein. That must be very clear. We can recanalize the tract, we can recanalize IVC, but we cannot stent from the GSV because the distal landing zone is 4 centimeters more distal. So we need a jugular approach additional. So you see, we tried to recanalize. We had some success on the right side. Left side, we tried also. Very important is this picture. If you deal with IVC recanalization, please at least 1-2 times go to the lateral view and ensure that you are ventral to the vertebral body. Because sometimes in an AP, you recanalize somewhere, you think it is okay, but you are in the spinal collaterals. And we had one case from University of Tehran. They created in the patient, because of an aggressive anticoagulation and bleeding, a permanent paraplegia in a 37-year-old patient. So be aware, if you see your wire is somewhere here, dorsal or in the middle of the vertebral body, come back, go to a new way. Here we did some, I would say, few centimeters. Here we could go through the right iliac, but please notice left side was easy, but from the right side, we couldn't get into the IVC. That was difficult. So what we did is we ensured that we are in the left side from the right side. So it was a correct crossover recanalization. With that, we came a little bit back with the help of the Triforce catheter, and then we traversed the pathology into the IVC, as you can see here. These are some techniques you can use. You can use also sharp recanalization, but then you have to take care for your anatomical way of recanalization, because a sharp recanalization goes straight. After recanalizing IVC and bilateral iliac and right side femoroiliac tract, you have to do the predilation. Also here, Professor Avgerinos already mentioned it. There was a occluded or chronically changed part of the SVC. He decided to predilate and to stent. The same is here. You have to predilate the entire way with a balloon at least as big as you are going to stent. You see here, we did a double ballooning with a 1640 Atlas Gold. And in the groin or common femoral and external femoral, we use the 14 to 40. Any remarks, questions?
What about the role of IVUS in this particular situation?
Yes. So the role of IVUS is clear, I think, in our group or in big venous centers. You need IVUS for determination of proximal and distal landing zone. This is a must to have the best. Of course, maybe there are cases you can do it without IVUS and it will maybe go well, but to make it perfectly, you need IVUS. Additional to that, with IVUS, you can measure properly the diameter, the length, you can reduce radiation exposure and contrast.
And also another question from Egypt. Do you believe that the visualization with IVUS sometimes overestimate the patency, and if you perform a phlebography, you have a better flow as you believed if you have done IVUS? So do you see correlation of IVUS and phlebography? Or sometimes I would say if IVUS has some, let's say, shows some worsen outcomes compared to phlebography.
So what is important here, these are complementary tools.
Yes.
What is important that there are some kinks of the stent, some pathologies, some details which cannot be detected by phlebograph. Very easy.
Okay.
The best inflow or the ostium of the deep femoral vein as the distal landing zone can be somehow seen and visualized by phlebo. You can put a balloon below the ligament, dilate it and give a dye and it comes back, but it is not perfect because it is overloaded by the femoral and common femoral,
Yes.
It's not perfect. IVUS is needed. There is no discussion.
Excellent.
So now you can see, as Professor Avgerinos mentioned it, this is our access, which was GSV. Now we would like to secure the inflow and to go for the best distal landing zone. So we went from the jugular access. You see, we wired the main tributary of the deep femoral vein. And now we decided to do the IVUS to determine the proximal landing zone, as you can see. And then we decided to go for a skip stenting technique. We used mono stenting, not a double barrel. We took the biggest available dedicated venous stent. You can see here. And then we post-dilated the stent. That is also a must. With a short overlap of 2 centimeters, we went for lengthening of the IVC stent, again with another dedicated venous stent. And then we decided for reconstruction of the IVC. Please forget the 2 left reconstructions. We decide always for one of those 3s. And in my center, we do either double barrel or skip stent technique with Gore stents, which is an ongoing study. Maybe the confluence will get a little bit more comfortable. So in this case, we went for skip stent technique. As you can see here, we pre-dilate everything. And like a tunnel, you don't have support in each centimeter. You have a pillar here and the next pillar is 1 meter far. Here you leave a small 5 millimeter to 1 centimeter segment. You end your IVC stent and then you take 2 dedicated iliac stents, as you can see. Here, 216 to 150. That is our publication about skip stent technique. Is not important. And then we lengthen the right side, of course, into the common femoral vein. As you can see here, the predilation of the main tributary of the deep femoral vein. And with IVUS, we determined the distal landing zone. And with that, we could skip an endophlebectomy of the common femoral vein, which is an additional 2-3 hours of procedure. I jump here. And that was the end result. As you can see from jugular approach, we are deploying a 14 to 100 millimeter dedicated venous stent, and the distal landing zone is exactly above the ostium of the deep femoral vein, which we determined by duplex. So that was before and that was after. So, and why not endophlebectomy? Because we did a publication, as you can see here, in a single center study in the same group of the patients. So we compared apples with apples. And in one group, we did the recanalization plus endophlebectomy in those for a group of patients. In the other group, we did only the endovascular technique. Patency rate was the same, but the patients who had only endovascular technique had shorter in-hospital stay and less complications. Thank you.
Thank you. Thank you very much, Houman. We are more than glad to hear more about this on Monday, the 28th of April in Frankfurt. And let's go to our last but not least speaker. Alex, we're more than glad to hear your talk. Thank you very much for your participation today.
Thank you very much for the invitation. It will be much easier case that presented by Makis and Houman. So I will say my disclosure. I have nothing to disclose. So this is a patient, 47-year-old patient, quite skinny, without previous intervention, without AVT or DVT. She had 2 pregnancies, 1 cesarean section. And as you can see, she has a visible varicose veins on the left thigh and perineum. Also, here you can see that the varicose veins are coming from pelvis, and they are located on the left thigh and also on the right buttocks, so bilateral varicose veins coming from pelvis. Of course, when we have such patient, we also have to ask the patient about the pelvic symptoms, if the patient has them. And as you can see here, she also had a chronic pelvic pain. On the visual analog scale, it was 7 in the 10. She had also dyspareunia and the pain after intercourse, and also menstrual cycle disorders. So generally, we have to remember that in such cases, when we have a patients with a pelvic origin varicose veins, most of the patients, so based on the study, more than 90% of patients do not have pelvic symptoms, but less than 10% may have additional pelvic symptoms which can cause their disability. And of course, she had also symptoms on her leg and perineal area. So she had the heaviness in the perineum at the end of the day after a longer standing. And of course, she came also because of the aesthetic reasons. So she wanted to get rid also additionally get rid of the varicose veins. And of course, based on the guidelines, I don't know if you perform, what examination would you perform? So Houman, what would you do in such case? You know, you can see the photos. I usually do transvaginal ultrasonography. I'm also a gynecologist, so for me it's easy.
So, as I am only a vascular surgeon and male vascular surgeon, in my outpatient clinic, I do not feel very well, so I cannot do it. I didn't learn it. And if I would learn it, to be honest, I would prefer you would do it and I can skip it to do a transvaginal ultrasound. Yes, I don't do it. With transabdominal, I think we discuss it a lot. I can see enough, but of course not as much as you can see.
Yes, for
this is a fantastic recommendation and message. I don't know how many vascular surgeons are aware about this slide, dear Alex. So even if your case is not so sophisticated like the other ones, I think we learned this from you, and I'm more than glad that you are today with us, because I think this is something we should stay. And I would say it's also a recommendation, a clear recommendation. And thank you very much for this information, because I had also a few cases, and this is also crucial. How can you confirm this pathology? And this is the difficulty also.
Yes. So based on the ESVS guidelines, we should consider to perform transvaginal or transabdominal ultrasonography. I generally do both. You have to remember about the position of the patient. So generally do not do the examination in the lying position. You should have it done to Trendelenburg position, just to be sure that we do not overdiagnose if there is a compression, and of course about changing the position during the examination. And I will show you how the typical the typical varicose veins looks like. So this transvaginal ultrasonography, based on the randomized control trial, when you see that the vein, arcuate vein, which is crossing the uterine body more than 5 millimeters, it's very characteristic for patients with chronic pelvic venous disorders. Also, you can see bilaterally peri-ovarian and peri-uterine huge varicosities, and also near the cervix huge varicosities more than 5 millimeters. Also, the varicose veins is a vulva, so you can go lower and you can see that there is a connection of these veins with the veins in the perineum. So it is a perivulval varicose veins, venous plexus. And of course, it's very easy in transvaginal ultrasonography also to assess the reflux. So here you can see that the patient has a reflux. In that case, very often the patients do not have like 7 seconds in reflux. Usually it's like 2-3 seconds, but of course it's showing the pathology. And of course, we have to perform transabdominal ultrasonography. We have to check left renal vein if there is a compression. And you can see here that the patient didn't have iliac vein compression. Also, there was no reflux in internal iliac vein. Now you can see that the left ovarian vein was not that dilated. It was like 5 millimeters. In general, it was norm. The right ovarian vein was, I don't know if you can see that, it was also not that huge. It was like 7 millimeters, so dilated. And you can see the reflux in the left ovarian vein. So this was the only pathology which I can observe in the transabdominal ultrasonography. Whenever, you have to remember that whenever we have a patient who is skinny, when we perform the ultrasonography in the lying position, we very often see the compression. So remember to change the patient position to ask him to sit, and also to inhale, take a deep breath, and also shows that there is no compression. So I decided, because the patient had the pelvic symptoms, so I decided to do the pelvic vein embolization or by pelvic vein treatment. So in that case, I usually send the patient for MR venography, and here you can see this how it looks like. So you can see a huge varicose veins around the uterus and also the pelvic escape points. And also here you can see that the patient had right ovarian vein was a little bit dilated, as I managed to see on the ultrasonography, and also varicose veins around the uterus were also visible. Left ovarian vein was not suspicious. And we have to remember that whenever we have a patient with the varicose veins, the huge varicose veins coming from pelvis, very often it's not related with the ovarian veins. Very often the tributaries of internal iliac vein are involved in the varicosities. That's why whenever we want to perform a treatment, you have to always check the tributaries of the internal iliac vein. And of course, based on the guidelines, whenever we have a patient with the symptoms requiring treatment, pelvic symptoms, pelvic vein embolization should be considered to reduce such symptoms. So, as I told you, because the patient had also varicose veins coming from pelvis, we checked both sides, the tributaries of internal iliac vein, and we found varicosities there. So we decided to do embolization. We used 3% polidocanol and also use penumbra coil. So we call this varicose veins. And of course, at the end, we also checked the right ovarian vein, which was also refluxing with the varicose veins there. And we also performed the embolization of this ovarian vein. This was our first approach. And the patient, after the treatment, it was 4 months after follow-up, you can see that nothing has changed in her varicosities. She had a slight pelvic vein improvement. So on the visual analog scale, it was 5, but generally no improvement regarding the varicose veins. So we decided to perform another treatment, so second pelvic vein embolization. And here you can see that there was also, in the film, you can see that there is internal pudendal incompetency, and also there is still an obturator there which is incompetent, which caused the varicose veins on her vulvar area. So we decided for another embolization. So we also did sclerotherapy. We're using 3% STS in that case, and also did the coil embolization. Here you can see how it looks like. And we also checked the ovarian vein just to be sure, because we didn't want to have a previous next intervention. So we also did the embolization of the ovarian vein. And wait, it doesn't work. I don't know why. Oh, yes. And 9 months after the treatment, the patient didn't have any pelvic symptoms. So the symptoms disappeared completely. She was very happy about her pelvic vein treatment. But unfortunately, there was no improvement regarding varicose veins. Nothing completely changed, even though we performed embolization of distributaries of internal iliac vein using also foam sclerotherapy. So I decided in that case, based on the ESVS guidelines, whenever we have a patient with the varicose veins coming from pelvis, the treatment, local procedures for varicose veins and related pelvic escape points should be considered as initial therapeutic approach. So in that case, I usually perform transperineal duplex ultrasonography. If you have any comments or questions regarding my previous intervention, you can ask or comment.
Thank you. Excellent. Excellent. Thank you very much. We are more than glad to learn from you on the first day of the AVC meeting on Monday. You have also a workshop on with focus on this pathology. We have more than 30 registrations for the workshops already. Do you have also?
Yes, I have more. But I just wanted to know if you would like to comment on the previous intervention, or just should I go for?
I think the previous intervention, which coils have been used, Alex?
Yeah.
The penumbra coils?
The Rabi penumbra, penumbra coils.
Yeah, they are very long, the penumbra coils.
So I like them. Yeah, 60 centimeters. Yeah. I like them. You can treat almost the whole vein with the
you use 1 or 2. Yes, perfect. And what is the foam you use in a coiling and foam sclerotherapy of the ovarian veins, not for vulva and escape points?
Yeah, in the first 3% STS or polydocanol, depending on what we have in the hospital, which I work. Now we usually perform with 3% STS because it's stronger. I generally prefer this, but both are good. But 3% usually, and foam.
Alex, I'm looking now at the varicosities, and I understand you're going to do foam. But do you get an equally good cosmetic result, foam against the stap phlebectomies at the thigh level, lower down? I mean, obviously, at the labia level, you're going to do foam, but further down at the thigh, is it still foam, or you prefer stap phlebectomies?
I generally prefer foam. I have a very good results with foam. I don't have any huge hyperpigmentation. Even if we have hyperpigmentation, it will disappear after 1 to 3 months, and that their results are good. Everything depends on your skills, I think. So, of course, in the perineal area, definitely you will not do phlebectomies, but on the thigh, whatever someone can do or feels better in that there is no. Based on the guidelines, there are the same results we can achieve, and there are comparable techniques. So whatever you prefer, I think. I generally prefer sclerotherapy.
Let us ask you like this. You have, every day you work, you have 15 to 25 patients, and many of those patients have varicose veins, vulva and leg, or only leg. How often do you perform mini phlebectomy? Because you laugh on me if I say I did a mini phlebectomy. How often do you perform that? Because you do everything with foam nearly, with good results.
Generally, rarely, extremely rarely perform a phlebectomy. If I have an option, I do theta technique, so total thermal ablation. So I perform thermal ablation of the huge tributaries. For smaller tributaries, I do sclerotherapy, maybe even less than 1%.
One question from the audience. What about Alex, polidocanol 2-3%?
Yes, it's also okay. So yes, I like it as well. Generally, I prefer STS because it's stronger based on the studies. It's much stronger than polidocanol. But of course, it's the both are very good. So I cannot say that one is better than the other one. And you know, in many countries you do not have STS. In some countries you do not have polidocanol, so they are comparable.
Excellent.
So maybe I will go further because we are running out of time. So I performed transperineal duplex ultrasonography, and here you can see that there is an intermediate labial pelvic escape points on the both side. So it's a escape point which is located in front of the vulva, in the space between in front of the vulva. So here you can see how it looks like, and it is connected with the varicose veins located on the labia majora and also a leg. They were quite big, like 5 millimeters. So this is how it looks like. Here you can see the anatomy of the perineum, and they are all tributaries of internal pudendal veins. So they are located in the vein of the vestibular bulb, and that's very often pelvic escape points, which you can find when you perform transperineal duplex ultrasonography. Here you can see the film. So in here it's a clitoris, and when you go lower, you can see this huge intermediate labial pelvic escape points, which were the reason of the varicosity of the patient. Yeah, let's go. And so I decided to perform venography and check why the pelvic escape points were not closed, even though we perform coil embolization and sclerotherapy top down. So it should then generally close this pelvic escape points. But unfortunately it didn't. And you can see that the foam goes directly to the place where we inserted the coil. So generally, I don't know why they didn't close the pelvic escape points, but unfortunately it didn't. That's why, based on the guidelines, whenever we have a patient without pelvic symptoms requiring treatment, local procedure from below should be considered as initial therapeutic approach. And in such patients, coil embolization very often do not bring good results. Based on the study, almost 90% of patients after coil embolization required additional treatment for varicose veins of pelvic origin. And also on the left side, in this case, I performed sclerotherapy. Here you can see how the foam is migrating to this pelvic escape points and also close the varicose veins on the perineal area. Yeah, and it's how it looks on venography. And on the similarly on the right side, here you can see this huge intermediate labial pelvic escape points, my approach. So I did the puncture and I also performed venography. And also here you can see that it goes directly to the place where the coils were and foam sclerotherapy was performed. And it also didn't close the pelvic escape points. And I performed also a foam using for pelvic escape points. I usually use 3% fibrovein, so STS, and I close the pelvic escape points. Here you can see how the pelvic escape points look 1 month after the treatment. So you can see that they are fully closed, occluded, so thrombosed after sclerotherapy, and the photo of the patient after such treatment. So I performed the total sclerotherapy of the whole leg. The first was vulvar varicosities and pelvic escape points, and after a month, I performed further sclerotherapy for the varicose veins on leg and the buttock. So the results are good, and patients are usually very satisfied with such treatment. Now, so in conclusion, so varicose veins are a common issue affecting women in all age. Patients with extrapelvic varicose veins usually do not have experienced pelvic symptoms. And for those with pelvic symptoms related with pelvic vein incompetency, of course, treatment of pelvic veins should be considered, and effective treatment of extrapelvic varicose veins of pelvic origin can be achieved through local procedures such as sclerotherapy performed from below. And thank you very much for your attention and for your invitation.
Excellent. Thank you very much. We learned a lot. We joined this excellent talk and webinar. I have one question from for Houman and one from the audience, and I think also one other nice question from Makis. I would say let's give us a short answer because it's nice. For example, Houman from Faras, he's asking, we know that stents are not recommended in the groin, at least when we have arterial lesions. Is this different when we are using the Abre in veins?
Yes, it is not. So let us remove Abre. All dedicated venous stents can be used below the ligament, and they should be used, please. They should be used if post-thrombotic changes are in the common femoral vein. And I can tell you, this is maybe in 60, 70, 80% of our cases, maybe 80 or 90% of our cases. So use it. Do not think arterial, think venous. So dedicated venous stents should be used. Yes. And I answered it also in the question and answer area.
Excellent. And Makis, the question about your case. So now after your successful treatment from UK, Thomas Hall is asking, how is now able the patient to receive chemo? How was this given now?
So
because you move it.
The patient is disease-free and he didn't actually need it. Now, if we have to gain access, I would probably consider going through the groin. I wouldn't want to mess up with the stent, placing another port through the stent and so on. Maybe consider a PICC line through the right brachial vein, or consider the groin. I wouldn't go back to the stent area.
Excellent. And Alex from Spain, again, one question. When performing pelvic sclerotherapy, what is your volume limit for each session? I don't know if you highlighted this.
Yes, no, I didn't say that, but generally I use a lot of foam. I usually try to not exceed 40, but 40 is a lot. So I usually use 40 foam for per
Okay. Thank you very much, dear colleagues, for your time and for the excellent webinar. I think we learned a lot. So we noted 2 dates, end of April in Frankfurt and in October in Athens, when we have the Venous Symposium Europe. We are more than glad to welcome you there and to learn more about venous pathologies. Also, our thanks to Radcliffe for the excellent organization and for the big pleasure today to have this great webinar. Thank you very much. Ciao.
Bye.
Bye.
Thank you.